Good morning, everyone, and thank you for joining the Clallam County's Coffee Chat, Coffee with Colleen. We're really happy to have our friend and partner, Priya Jayadev, on with us. She is the Executive Director of the Volunteer Hospice of Clallam County. And we're going to start things off this morning with the video, but before we get going, if you'll put yourself on mute so we don't inadvertently pick up background noise. And if you have any questions for Priya, please feel free to raise your hand, or alternatively, you can put your question in the chat and we'll go ahead and ask the question on your behalf. So with that, take it away, Priya, and thanks so much for joining us.
Thanks, Colleen and the EDC for having me on. This is important to me because I want to elevate the conversation about death. And so with that statement, I want to start with a clunky video. I want to say it's clunky, but it makes a very important point, and I want to start with that. And in the video, they're going to talk about a fire and a fire department. And as you're watching it, substitute death for fire, and for fire department, substitute the word hospice, the hospice organization. Okay. So now I'm going to try and share. With that said, share sound. Let's see if I can get this to work. Can you see a video?
Yes.
Okay. And hopefully this will work.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
So I think you probably got the point there that oftentimes we live in a culture that is death phobic, right? And so let me just start my presentation slides and see if I can get this to work. So we live in a world that is a death phobic world, right? And in that video, what we were talking about is yeah, you're the fire department, but don't say the word fire. And in our area of work, oftentimes we hear this piece of, yeah, but we don't want to tell the patient that they're dying. Yeah, and we have this taboo around the whole word of death and dying. So what I would love to do is to change that, to make death and dying a part of regular conversation because it's important. And just to acknowledge the fact of why people consider it a taboo topic. People don't want to acknowledge their mortality, but as John Cleese says, life is a terminal disease. So talking about death is an important thing, although many people think that talking about it means that it's giving up, and it's an uncomfortable topic. It brings up all the feels, right? So there's all of those concerns. But it's really, really important to talk about it, and recognizing that death is going to happen helps us appreciate the present, of course. It motivates us to get things in place so that when those who survive us have to manage our affairs and things, they're ready. It motivates us to make sure that we have the right advocates in place so that they can support us in making the wishes happen that we want to happen when we don't have a voice in that dying process. That's an important piece. And it helps us prepare for what's known as a good death. But then people will ask, what does that mean, good death? So there's data out there. There's a ton of papers published on this topic, but it essentially comes down to parameters that people find are important in the dying process. So in one particular paper that's cited here, they came up with 13 parameters, including, pain and discomfort are managed. The person who's dying is in a clean, safe space. They're treated kindly. They're treated still as human beings, even though they're dying. So not just as a patient, but as a person. The quality of treatments that they're getting are actually leading to good quality of life, that they have information in a timely fashion that is easy to understand. They're able to ask questions, they can cope, they can get care that's well coordinated. There's a whole series of parameters that have been defined as key parameters that define a good death. And if you look at a study of numerous countries, the United States gets a C. We're in the rank of Colombia and Myanmar and Mexico in terms of our availability to provide a good death to patients. Because many patients are dying in pain, they're experiencing serious suffering, they're not necessarily dying where they want to. More than 80% of Americans say they want to die at home, and only about 25% do. Many die in hospitals, in facilities, but elsewhere than where their choice is. There's significant distress, there's regrets, and there's all kinds of factors that lead to the US getting a C grade. But the one thing I can say is that as we talk about death and dying, as hospice and palliative care come into play more and more, the quality of life is improving for the end of life situation, with more of an adoption of palliative and hospice care. So I'm throwing around this term palliative, hospice. What the heck does that mean? Palliative and hospice care focuses on comfort, it's on quality of life, and it's for the individual that has a serious illness. And I want to illustrate this concept to you with this diagram. And Mitch, I think I sent you a link to a document that is the palliative care roadmap. So if you want to drop that in the chat, that link in the chat, that gives you some information about more information about palliative care. But I just want to go through this diagram with you. So a person gets a life-limiting illness diagnosis. At the beginning, when that diagnosis comes in, most patients choose to pursue curative treatment. And for a time, they'll undergo curative treatment. And for many, the curative treatment is successful. For some with that life-limiting illness, the majority, it's life-limiting, right? It's a curative treatment, but it's really not leading to a change in the course of the disease. And so as the curative piece actually leads to more and more pain and suffering and less quality of life, something comes in that's called palliative care. So curative is decreasing as palliative care is increasing. And the idea is that the focus is shifting in care. The focus is shifting from curative to comfort and quality of life. It's shifting to emotional and spiritual support, not only for the patient, but also for the family. And arbitrarily, we can say that as curative treatment completely goes away and the focus is completely on palliation, it becomes what's known as hospice care. And as Medicare stipulates, that time course is one in which if the disease follows its normal trajectory, that patient would have 6 months or less to live. So it's an arbitrary definition that hospice care is the last 6 months of palliative care, but it is how the US defines hospice care as Medicare-funded hospice care. So curative, shift towards comfort and quality of life, it becomes palliative. Hospice shifts towards really terminal stage of disease. And then, of course, after death, there's the bereavement care that can be received by families in the hospice palliative model. Does all of that make sense to everyone?
Mhm.
Okay, so if I can go to page, there we go. Just as a little bit of a understanding of how palliative and hospice care is delivered, it can be delivered in different settings. Most hospice care, at least, is delivered in the home. But it can be delivered in a facility. It can be delivered in hospitals. It usually involves an interdisciplinary team, which involves a number of disciplines. And I'll talk to this a little bit more as we get into a little bit about volunteer hospice, but there's a number of disciplines that support and coordinate the care of the patient. If we talk about who pays, hospice is something that is paid by Medicare, Medicaid, and various insurances. But palliative care to date is very limited in that most people private pay for palliative care. There are a limited number of insurances, HMOs, that cover it, but generally palliative is private pay. There is a large discussion at the state and federal level about whether palliative care can be paid for through a Medicare type model. And that is something that is probably going to come into more prominence in the next couple years to decade. The benefits, of course, of having palliative and hospice care is that there's symptom management, there's support for patient and family, there's a coordination of care. And the focus is not just on doing everything for the patient, but it's on that piece of let's make the patient, the person that is experiencing end of life, as comfortable as possible with the best quality possible and achieving the goals that they want and that the family wants. That is the key to palliative and hospice care. I keep clicking on things and it's not working.
Priya, it looks like you have a reminder notification on your screen.
Sorry.
Yeah.
Oh, you're good. And then it looks like it's presenter view. We can see your next slide in your notes. It's totally fine. Just want to make sure that's the way you want it.
I think you need to go to display settings. On that.
Let's see. I thought I had it right when I
It was
tried.
working.
I sent you a chat to let you know.
Oh, sorry.
I should have said it out
There you
loud.
go. That's right.
That
That went
worked?
great.
Oh,
Yeah,
okay.
yeah,
Of
that
course I
worked.
quit. Okay, so let's try that again. Sorry. Okay, is that?
Perfect.
Yep.
Yes. Okay. Sorry about that. So I just want to tell you a little bit about the history of hospice. So hospice came to the US. Hospice is an age-old concept. It emerged in the Middle Ages, but it kind of went to the back burner for a long time. It kind of reemerged in the European setting in the early 50s and 60s, and then emerged in the US in the 70s. And initially, hospice was one thing, and it was the only thing that was really recognized. Palliative care really wasn't in the picture. But by 1974, palliative care emerged as kind of a separate entity. And as I described it, it's not a separate entity. It's like palliative moving to hospice as this natural transition, right? But the US has gone through a very cycle of history around the concept of hospice versus palliative. Is it separate? Is it the same? And today, the idea is that palliative care is earlier setting of support for a patient, and hospice is a subset of palliative care that comes in towards the end of truly the terminal phases of life. But as history has had it, hospice care emerges in the 70s.
It is going to be a great day.
Sorry about
And
that.
then it became Medicare funded in the 80s. So the government recognized that there is extreme value in it. And as we saw, we still have a C rating in terms of our quality of end-of-life care. But in order for us to move towards better care, we need to move towards hospice and palliative care at end of life. And we have seen that initially the adoption of hospice care in the late 1990s, there was about a $2.5 billion spend on it. But as we look towards now, we're spending $20 billion and more on hospice care. There is greater and greater adoption of hospice as a modality for care at end of life. One of the other things that I just want to mention is that early on, it was all mom and pop shops. It was nonprofits that was delivering hospice care. Hospice care over the 2000s has emerged as a very profitable business. It is a business run by the United Healthcares and the Kaisers of the nation. And so there's been a transition in that there's been a fivefold increase in for-profit hospices. And there's been slight increases in the Medicare reimbursement model. It's a per diem reimbursement model on a per patient basis. The other thing that has changed in the transition from 1970s to now is that when Medicare was deciding to fund hospice, the majority of patients at that time were cancer patients. As we look to the majority of hospice patients these days, it's only 23% that are cancer patients. More patients are experiencing dementia and other Alzheimer's-like diseases, nervous system disorders, circulatory diseases, and a myriad of other conditions. So what that says is that the trajectory of cancer is different than the trajectory of many other diseases. So the mode of hospice being defined as 6 months or less to death may not be appropriate anymore. The other piece is that the reimbursement model has led to some issues with how billing and fraudulent billing has happened. And I think as we move to the future, one of the things we'll see is some changes in our in the hospice payment models, and some changes potentially to the modality of how much time someone can stay on hospice without having to be recertified for care. So these are all things that are up in the federal model being discussed, and keep an eye out for it. And I know when the reminder came out for my presentation, there were a number of things that I said I was going to present. I'm not really going to touch on some of the federal discussion points, but if you are interested, I can certainly take you through all of that in a separate conversation. So, having said that, now I can't, there we go. So kind of having set the background on hospice care on a national level, let's bring it to our side, right? In Clallam County, there are two options for hospice care. There's Assured Hospice, which is a Medicare licensed hospice, the traditional hospice that is out there. They are now part of United Healthcare. They used to be part of LHC Group. So LHC Group was acquired in early 2023 by United Healthcare. And so Assured is now part of the Optum division of United. They are a very important part of our community and are available, and they do hospice as hospice is done by the majority of hospices in the nation. And then there's us. We're kind of a unicorn. We're probably like 1 in 6 in the nation that we are aware of. We are different because Rose Crum, our oh, crud. Anyway, sorry, something's just popped up. Hopefully you're not seeing. Rose Crum was our founder, and she brought hospice to Clallam County in 1978. And essentially that's within 4 years of when the hospice concept had emerged in the US. So this was a visionary nurse in Clallam County said, I want to make hospice happen here. Many people were very much opposed to it, and they thought there was no need for that here, but she was very adamant and she made it happen. That vision continues today. And when she created volunteer hospice, it was in the mode of most of the hospices at the time. It was a small, independent, community-based, free hospice service that was available to anyone. It was on a nonprofit model. When Medicare came into the game in the 1980s, Rose was again very adamant about the fact that we remain free, independent, community-based. And so she mobilized her son, Patrick Crum, and Derek Kilmer, who was at the time in the state legislature, not at the federal level, And the two of them put Rose in front of the legislature so much that they carved out an RCW exemption so that we do not have to bill Medicare or anyone for our services. So that was Rose's vision: stay independent, stay community-based, focus on what this community needs, and be responsive to that. And so this RCW exemption exists only in Washington State, as we know, and therefore we are the only ones that use it to operate as we do in the state. In other states, there are some free independent hospices, but they're very far and few. So we operate without billing anyone. So we are very, very unique. It also makes us a little different in that because we don't bill, we are focused on a revenue source being private donations and grants. That's it. Nothing else. Private donations and grants. And this continues to be Rose's Hospice as we operate. I want to put a little bit of context on that because even though we are different, I do want to make the point that we actually are practicing standards of practice in hospice care. We provide end-of-life care for life-limiting conditions. Our standards of practice are focused on comfort, that symptom relief piece, that distress of reducing that distress of stress, and producing physical and psychosocial relief. We are HIPAA compliant. We focus on quality, and I'll speak to that in the next slide. We provide medication support. We provide medical supplies, and in fact, the medical supplies and durable medical equipment that we provide is available to anyone in the community, not just patients on our caseload. We provide coaching to families on how to care for a patient because while we are available via phone or visits 24/7, we are not there 24/7. So the patient must have a caregiver in the home to support their care when we are not there to have eyes on. We provide emotional and spiritual support. We have a grief and bereavement program. And in fact, our grief and bereavement program is available to anyone in the community to reach out to and access. But we are different, as I said. We don't have some of the barriers that Medicare puts in place. So that 6 months to terminal is not a barrier to entry for us in that we have a palliative caseload, right? We allow patients to come on that are potentially have longer than 6 months to live. So long as they have a life-limiting illness and a nursing need to support their comfort and quality of life, they are eligible for our care, potentially. We do an admission visit to assess whether the patient is appropriate. And then at that admission visit, we will determine whether they are more appropriate for our palliative caseload versus our hospice caseload. We work in partnership with the existing care team of the patient. So we do not have a physician provider on staff. We do have nurses. We have nurses' aides. We have a social worker, but we do not have a physician provider. So the primary care providers, the specialty providers, home health, they all stay on the care team for that patient. We do not come in and take over. We come in alongside and partner with. That can be a challenge at times, but we are working on potentially moving towards addressing some of those challenges, and this does make us distinct. I will say that the majority of care delivered by hospices nationwide are delivered by nurses and nurses' aides, and they are the key focus of our care as well. The patient can continue curative measures. Now, let me just step back and say, quality of life is the critical piece, right? If a patient chooses curative measures, obviously we support them in that decision. But the idea isn't that they are pursuing curative measures. They do recognize that it is end of life. But if a patient wants to try to survive 6 months to attend their daughter's wedding, for instance, that's that opportunity to, if that curative measure will allow them to extend life for 6 months so that they can attend that wedding, that's fantastic. Absolutely, the patient can pursue that. As opposed to Medicare hospice stipulates that all curative treatment is for the primary diagnosis is no longer pursued. We don't have that stipulation in place. As I said, we don't bill. Instead of a billing department, we have a donations department. We have flexibility to provide extensive support. We had a nurse who was in a home for about 4 or 5 hours this week in a death visit because the family needed that support. And we have that flexibility to allow that care. That is not the goal every visit because we could not operate if we weren't doing 4 and 5 hour visits every time. However, we do have that flexibility when it really is needed. And then the patient continues to use their Medicare and insurance dollars for all the things that they normally would. I spoke briefly about quality in the previous slide. We have quality that focuses both externally as well as internally. We do send out a survey that assesses the normal things that every hospice is required to evaluate as their quality measures as they report to Medicare. Those are the same things that we ask our patient families to report back to us through survey modality and through verbal contact. And then we have some internal facing quality measures that are focused on documentation and staying as compliant and appropriate in delivery of medical care as possible. And then just as nuts and bolts, we have 13 full-time equivalents worth of staff. But if you look at the number of staff we actually have in place, we have a lot more staff than that. The point being that the majority of our staff are part-time per diem staff. Only a few of us are actually full-time. We have nurses, nurses aides, patient navigator, social worker, and mission support, which is, I am part of mission support. We are here to support that team. And part of mission support is our volunteer services manager, Astrid Reffenpillows, who manages a cohort of 195 volunteers. About 154 were active in October. And when I talk about 195 volunteers, that's doing all kinds of jobs from respite and grief support, both group and one-on-one, death cafes, chaplaincy, spiritual support, lending closet, running our front desk, doing deliveries. Our volunteers are incredible, and they do all of the work of that. We couldn't do this work without them. We could not run our front desk without our volunteers. They are the core of our business just as much as our staff. We have a current census of about 104. I say 20% hospice, 80% palliative as the normal definitions are, but you'll see in a subsequent slide that actually this is an arbitrary definition. And when you actually look at our caseload, even if we bring them in as potentially palliative, many of them are actually hospice appropriate in that they actually do die within 6 months. Even if we define them as hospice or palliative, it's an arbitrary piece, and it has to do with how we care for them. We meet the patient and family where they are at. If the patient and family really do need daily visits, then they are put into our caseload for daily visits. If they need weekly visits, then they're put into our caseload as weekly visits. If it's a touch base every month, every 2 months, that's how we care for that patient. We meet the patient and family where they need to be. Our caseload is equally distributed between Squim and Port Angeles. Our area of service ranges from Joyce to Diamond Point. We have about 19 to 24 admits per month, about 16 to 21 admits, deaths per month. And as I said, if you look at year-on-year data, the majority, 22% of our caseload in 2021 was palliative. The rest were hospice. So if you look at this graph, each year has a lighter, a middle tone, and then a darker tone of each color. The first bar represents patients who've died within 7 days of coming on caseload, right? That's what we don't want. Patients who only come on and have very little opportunity to be supported in that end of life journey. But there are a number of patients that come on later. And then there are the patients that come in and die within 8 to 180 days, within 6 months. So these two bars represent the 6 months, the normal hospice trajectory. And if you look at our caseload, about 18 to 25%, depending on year, of our caseload are actually hospice appropriate patients. I mean, our palliative, and the rest are hospice appropriate patients. And then I just want to emphasize that we're not just about hospice. We do a heck of a lot more. As I had mentioned, we have this lending closet that's available for anyone in the community. We have death cafes, we have a soul care program, we have resources, we have a grief support program. And our grief and bereavement program is eligible to anyone. We have individual grief support. We have grief support groups that meet regularly. We have practical workshops. So we've got something where families who have outlived their loved one can come and learn how to cook for one, and how to shop for one, how to do basic home repair, that kind of stuff. So practical workshops that run, I think, once or twice a year. We have an annual remembrance ceremony. This year, I believe it's in Port Angeles again at I forget, but it is in February always, and it's always on a Saturday. It's an opportunity for the community to come and recognize the loss of a loved one. Anyone in the community is welcome to join that. We have a soul care program, Tea to Die For, which are death cafes, a mechanism to elevate the conversation of death and dying, any topic that the attendees want to talk about. We have a speaker series. We have death doulas, just like birthing doulas, death doulas can be there to support families and patients. And then, of course, our lending program, which is extensive, and we are truly reliant on our volunteers for a lot of this to happen. These are the numbers, which I'm not going to go into, but January to November, so far we have served 298 patients with almost 1,900 nursing hour visits and almost 1,300, over 1,200 CNA visits, and a lot of support hours. Our admissions and deaths over 2024 in the 200s or close to, and we have a lot of volunteers that are putting in a ton of time doing a lot of the support services for us. Just want to touch on the financials. This is income over here, and I don't know if you can see my arrow, but income on the left, expense on the right. And what you see is that the majority of our income, 27% from donations, 27% from extraordinary gifts so far this year, have been from just individual giving. 3% has come from grants. And if you look at it, 3% of the cost of programs comes, the cost is from programs. Grants directly support the program cost that is not human capital. Human capital, the provision of service, is our majority of our cost, and that is provided by our regular budget, but the grants support that programmatic cost. So we really rely on program costs being covered by grant revenue. This year, unfortunately, has been a lean year, so we have had to rely upon our reserves. 40% of our income so far this year has been reserves, and that varies year to year because we can't predict what comes in the door as individual donations. In 23, we only had to draw on reserves 3%. 22, not at all. In 2021, 19%. My goal is to keep it at 10% or less on a year-by-year basis if I can. Just the faces of the angels I get to work with on a day-to-day basis. As I said, we have a mission support team. We have our clinical team manager and our lead nurse and our patient navigator, our cohort of part-time field nurses, our per diem field nurses, and our CNAs. And we have a board that many of you may recognize the individuals on this team. They are an incredible team. And working at a nonprofit, I can be proud to say that we have a leadership, a team, a staff team, and a volunteer team that are all in the same boat, on the same river, rowing in the same direction. And that's often hard to say at nonprofits. And the fact that I can say that is just an amazing thing for me. And it looks like I might be running out of time, or do I have a little bit of time to cover the caregiving crisis?
Sure. You have more time. Go ahead.
Okay. So I I know this is not completely hospice related, but I want to put a pin in the fact that there is a caregiving crisis out there. Marilyn Waring, who is an economist from New Zealand, says that the gross domestic product is a system that counts oil spills and wars as contributors to economic growth, while child rearing and housekeeping are deemed valueless. Valueless. And that is a problem. And we need to change that. Caregivers are part of our community in many aspects. And I think, Colleen, you've had various people come talk from the child rearing side and caregiving on that end. But there's also that caregiving side in the older generation side. And we also have the statistic that there are women, especially in this sandwich generation, that are carrying down and carrying up. They're that sandwich carrying both directions. And it's not just women, it's men and women. And sometimes it's children carrying up. So there's a lot that's out there that we need to be talking about. And if you look at the caregiving economy, the cost of having families doing the caregiving instead of paid caregivers doing the caregiving. In 2007, the cost savings to the US healthcare system was $375 billion. It has gone up to $600 billion. This is an issue because families are saving the economy, the healthcare system, but it is a huge burden for families. If you look at the numbers, greater than 21% of the population are providing care for someone who is an adult. 78% that need long-term care depend on family and friends. 57% need help with medical and nursing tasks. 42% of caregivers are caring for parents. 75% of caregivers are women. The average amount of hours spent caregiving, 24 to 41 hours per week. It has impact. It is a huge concern and something that needs to be addressed. We need to strengthen the care infrastructure in our nation. It is a huge burden, both financially, health-wise for the caregiver, and the fact that there's this huge burden in that caregivers are being thrown into these roles and they don't know what they need to do, how they can do the work that they do in caregiving, and they don't know what resources to reach out to. So this is something that we need to address, and I just want to prime that as a thought. And also, if you're a caregiver, it's important that you do self-care, that you take care of yourself, that you seek support, that you accept offers for help, and you learn about what resources are out there in the community that can support you. So resources like Olympic Area Agency on Aging and Tim's Place, OLICAP, support groups, Encore, Lois's Legacy, all of these are available to support caregivers for seniors. The fact that there are home modifications that can support the caregiving process, that the technology modalities emerging that can support that caregiver, and that there are service providers that do everything from house cleaning to meal delivery to nurses' aides and home health. And then just a bit of, there are caregiver agencies that do paid caregiving. There are ones that take Medicaid funding, and there are ones that are private pay, and there are also independent providers that you can be put in touch with through O3A or Olympic Area Agency on Aging. And the idea that I would like to see happening is that we shift the narrative, right? Care right now is invisible and undervalued. Caregiving is an individual responsibility. That's the current narrative. Let's shift that to caregiving as a collective responsibility, and it's a valuable, important work. And we need to be advocates for the caregivers in our community. There are changes happening, and those changes include Health and Human Services at the national level have put together a strategy to support family caregivers. And I think I've sent the link to you, Mitch, so if you could put that in. States are expanding paid leave for family caregivers. We need to continue to expand that. There's some states that are adopting family caregiving compensation programs. That's a unique model that we need to be thinking about. There are proposals for Medicare payments for training caregivers more professionally, and new payment models for care coordination and support groups emerging as well. So just to put a pin in the fact that if you ever get a chance, advocate for funding for caregiving. And I will leave it at that and stop share.
Great. Thank you, Priya. I think it is really special that we have volunteer hospice here. It's unique. And as you said, 1 in 6 in the country. I didn't realize that unique. That's really amazing. So Dale had a question. Dale, do you want to ask it or do you want me to read it for you?
Sure, I'll ask it. I'm thinking about assured and volunteer hospice of Clallam County, and I'm trying to figure out what the decision tree is. What ways are families that need hospice get informed, and how are these two organizations presented as options?
So usually a hospice referral can initiate by any provider, right? You go to your primary care provider, you go to your cancer care provider, you go to your dialysis, you can get a referral to hospice in any of those modalities. To be fair, in any community where there are multiple hospices, it is up to the family and patient to choose which hospice they would like to go to. And with any provider, interview them if you have questions, right? Find out who is going to give you the care that you would like. And as a provider, I would recommend that both be presented as options. And obviously there are various aspects of Assured or us that are different, and understanding what those differences are and how you can be supported in getting your goals met, finding that organization that meets your goals the best possible way is the goal of the family and patient seeking hospice care. So anyone who has a terminal illness, who wants to focus their journey, their end of life journey on quality of life, on comfort, on things that are not necessarily about doing everything you can to cure the disease, but on making that end of life journey the best possible, should be the individuals that are seeking hospice support. I don't know if I've answered your question exactly.
I think as good as you probably can.
Yeah. The other thing is, if a referral comes to us, it doesn't necessarily mean that the patient is going to be admitted, right? If we have decision criteria to determine if someone is appropriate for our care. Again, if someone doesn't need nursing level care, if someone doesn't have a life-limiting illness, if someone doesn't need that type of support that we are able to provide, sometimes what they're reaching out to us is for caregiving, then we will refer them to a caregiving agency, right?
Got it. So Dale's next question was, if a Catholic hospital acquires OMC, how will this affect the ability of VHOCC to achieve its mission, if at all?
I don't think it would have any impact at all. We are independent of any kind of affiliation. It shouldn't impact anyone's ability to reach out and access our services.
Could I ask
So-
a follow-up about that?
Yep.
There was a really good end of life workshop here about 1.5 years ago. And one of the doctors on the panel talked about how the Catholic organization that he was a doctor at was prevented even in his off time to do any end of life work. And there was a law that was passed, I think, in the legislature to prevent that from happening. But it seems like there's obstructions that occur with Catholic hospitals around end of life work. So I'm wondering if you could elaborate on that a little more.
Yeah, so Dale, I think you're talking about medical assistance in dying or death with dignity.
Right.
So Washington State is one of the states that allows death with dignity. So a patient who truly has a 6 month to death diagnosis, that prognosis, they can go to a physician and ask for medication to assist them in dying. So medical assistance in dying requires that two physicians sign off that the patient is emotionally and psychologically sufficiently of sound mind in order to pursue that, right, before doing that prescription. Physicians who are at some of the hospitals in the state that are Catholic affiliated or religious affiliated have had some mandates within that organization that they can't pursue it. We do not provide medication. We do not prescribe. We do not do anything in terms of medical assistance in dying except for supporting a patient as we normally would support any patient on our caseload. We are not there when a patient ingests medication, but we will come to pronounce, we will come to support through all of their journey, except for the time of ingestion of medication. So it doesn't impact us at all. If OMC were to become Catholic, would that impact their ability to have physicians approve patients for MAID or death with dignity? Possibly. I can't speak to that.
And Rebecca said, how does the family know when to pursue hospice? Is it only a conversation with the primary care doc?
So with Medicare hospices, you can, and with us actually, you can call us and ask if it's appropriate, but we will send you back to the provider for the referral for sure. If you want to have a conversation, ask about what's appropriate and, kind of go through your particular case with us, absolutely call us, call Assured, call and find out.
Got it. Great. So are there any other questions for Priya? Really great conversation today, and it's important. My mom passed away a year or more ago, and she had volunteer hospice, and it was wonderful, and we so appreciated everything. Okay, so we do have some questions from Dale and Daniel. Go ahead.
Another question about could you, for the folks on the call today, could you hum a few bars about what a death cafe looks like and how often they happen and where they happen?
So I'm looking, Astrid.
Yes.
Astrid is with us and she's from Volunteer Hospice. I'm going to ask you to answer.
Okay. So a death cafe is a very informal gathering of people who are curious and want to know more about death and dying, end of life, advanced planning, anything related to end of life. We operate 2 death cafes a month. One is in Port Angeles on the 4th Wednesday every month. Not this month though, because the 4th Wednesday in December is going to be on Christmas Day. So the next death cafe in Port Angeles will be January 22nd, I believe, the 4th Wednesday at 4 p.m. until 5:30 at the conference room 829 East 8th Street in Port Angeles. We also have a death cafe in Squim every second Monday of the month at 4 p.m. also. And this one takes place at the KSQM Community Room 609 West Washington Street in Squim. You don't have to register, you can just show up. It's facilitated by volunteers, and we just organize ourselves around tea, coffee, and cake, cookies, whatever little collation might be kind of informal and make it more convivial. We call those Tea to Die For, thanks to a volunteer who had a great idea to call it Tea to Die For because it happens at 4 p.m. A little nod here to John.
Great. Thank you. Daniel.
First of all, I want to thank you for putting this on. This is it's a tough subject to discuss and to talk about. I'm caring for my 98-year-old grandmother today, actually. And so thank you very much for this. Is there any strategies or anything that we can do to not only continue to echo and bring awareness of the gap that we have in this area, but also to even testify to our state elected officials to bring additional funding to this area?
For caregiving?
Actually, for projects and buildings that could support further care and empowering families to be able to, I guess, extend resources to family members in need.
Uh, um, I think just elevating my short answer is I don't know. But I think the more we elevate the conversation about caregiving, the more we elevate the need to our legislatures, the more the more people that talk about it, the more they'll hear it, right? It's that uh, a squeaky door gets oiled piece, right? I think that is a piece of right now. Caregiving is invisible. The people that are caregiving, they just do it, right? That perspective of there's this community piece of loss of income. There's this community piece of, you know, diminished health of the caregiver. There's this community piece of strain on our systems that needs to be continually talked about. And until it's talked about, people aren't going to address it.
I have to head out. Thank you so much, Priya, but Lori will continue hosting the meeting. So thank you again, and got another meeting I got to jump to. Thank you. Bye-bye.
Absolutely. Are there any other questions? If anyone does have questions, and if anyone would like to reach out and talk about what might be appropriate care or not, I'm available. You can reach out to me. I think I had my contact information in the slides, and Laura, you can definitely share that with anyone who asks as well.
Mitch, do you want to put her contact information in the chat really quick?
Yes.
Thank you so much for the presentation today. It's a difficult subject to talk about, but being aware and being prepared when it does happen, especially to family members, is super important to make sure that we have the tools and the resources locally here in Clallam County and abroad, depending where our family lies. And so we really thank you for being on the call today. And I want to wish everybody a nice rest of your week. And who is on Coffee with Colleen next week, Mitch?
Marie Keller.
We're going to be talking about childcare and resources that we have for that out here in Clallam County. So we look forward to seeing everybody next week. And Mitch has, let's see, him put the information down in the chat so that you have the contact. And we thank you all for being on the call, and we will see everyone next week. Thank you.
Thank you, Priya. Appreciate it.
Yes,
Sure.
be Priya.
Thanks, guys.
Bye now.
Bye.